Good morning, everyone. Thank you so much for joining us for another CMN virtual collaboration forum. We know 7:30 hits you pretty early, but we hope to start your day off right. I am a coordinator and moderator for this session. My name is Carrie McNabb, and I'm going to help you go through some introductions this morning before we turn it over to our awesome panel of speakers. First things first, though, I'd like to take a moment to give a land acknowledgement and ask that everyone just take a moment to reflect and consider where they are working and joining us from today. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory and is a traditional meeting ground and home for many Indigenous peoples. And our session today is AUD in Community, Evidence and Actions. Very excited to be having our session presented by Drs. Tally Mogus, Lana, Fehr, and Jessica Kirkwood. So we'll be handing it over to them shortly. A couple of disclosures. I would like to introduce our medical lead, Dr. Kathy Scrimshaw.
Good morning, everyone. I'm Kathy Scrimshaw, and I'm actually a part-time employee of the Alberta College of Family Physicians and have been a family doctor in Pincher Creek for a number of years.
Thank you, Kathy. And as noted before, my name is Carrie McNabb, and I'm a coordinator with the Alberta College of Family Physicians. Also excited, we have another coordinator who's joined us recently. Her name is Agatha. So if you get any emails from mentorship@acfp.ca, it'll be from her or myself. A couple of notes on our disclosure of financial support. So we do receive financial and in-kind support from the ACFP, and we've also received a contribution through the Health Canada Substance Use and Addictions Program. A couple of notes, these events are certified, so please ensure to fill out your attendance survey every session you get. So fill in your first name, last name, and email. That helps us track who attends and how to get your certificate of attendance to you. We typically do certificates twice a year, and if you ever have issues, email us at mentorship@acfp.ca and we can get those to you. So March is halfway through. We're already into April thinking. And that means we have 2 sessions that we're excited to share with you. Again, we've decided to mix up the time. We know that meetings are tough for people in the morning sometimes. So our next 2 sessions are going to be at 7 p.m., not 7:30 a.m., p.m. And we're actually going to be doing 2 different pain talks with Dr. Tina Koronik and Dr. Jessica Kirkwood from the Fehr team. April 20th is going to be back to basics, reviewing the evidence for the management of low back pain. 1 week later, we're going to go again at 7 p.m. and do Taming the Burn, evidence for the management of neuropathic pain. So these sessions are also open to non-CMN members. They are open to your teams. They are open to other CMN members. Agatha is going to post some links in the chat. Please share them. These topics and these sessions are completely open, so please share them. It's an open registration link, so the more the merrier. Please share that information. Evaluations, always important to us. We honestly spend a lot of time reviewing them. There is an evaluation link at the end of every single session, and if you enter the draw, you will also be in for a $25 gift card for a coffee card. We've had a couple of winners so far and excited to see that continue. Thank you in advance for filling out your evaluations. Now, without further ado, I'm going to turn it over to our speakers. They're going to talk for about 40-45 minutes, and then we're going to hold questions to the end. But that doesn't mean you need to not share your questions in advance. Please feel free to type in the chat log as the questions come to you, and then Kathy will be our moderator, and she'll help ask those questions to our speakers in the end. So without further ado, I'm going to hand it over to our speakers and let them get started on their content. Thank you and welcome to Tally, Jessica, Lana. Thank you so much for being here.
Carrie, thank you so much for having us, and the rest of the CMN and the ACFP. It's a pleasure to be here. I'm just going to pull up my slides and get the party started. And again, thanks so much for coming so early in the morning on the week of a time change, because that is still hitting me pretty hard. I don't know about you guys, but those never seem to get easier. So yeah, This is us, and this is the presentation we're going to give you. We're going to talk about alcohol use disorder and all kinds of parts of that. Our objectives really briefly are going to be to recognize and diagnose alcohol use disorder in your patients, to help understand and apply the evidence for treatments with medications and counseling, discuss withdrawal management options, being outpatient, and briefly touch on what inpatient options there are, and outlining options for intervention and referral to treatment service. So we will introduce ourselves and give our disclosures.
Good morning, everyone. I'm Mogus. I'm a family physician at the Boyle Macaulay Health Center in Edmonton. I work with Jessica Kirkwood, and I also work with the ARCH team at the Royal Alex. So I get paid through Alberta Health Services with them.
Tally is reporting live from the Boyle Macaulay this morning because her children are small and would likely interrupt her presentation. Like mine may, though I'm bribing them. So I hope they stay out of this room. All right, moving on.
Hi guys, good morning. Thanks for joining us. I'm Dr. Fehr, Lana. I actually have my own clinic in Arrowwood, very small town, south of the Siksika Nation, and I am on an ARP, and I am paid by Alberta Health.
I was lucky enough to meet Lana at the Family Medicine Summit 2 years ago at the CMN event before it started, and I was like in awe of the work that you do. So this has been really cool to do this talk with you and get to know you a bit better. Oh, just kidding. Cool slide transition there, Jess. All right, and this is me. I'm a little bit grimier than these guys. I've taken a bit of money, but only from really great people like the Alberta College of Family Physicians for doing talks. And after today, we all will have been paid a little bit of money to come see you guys and talk to you guys today. And I've done some consultant work with the medical panels office. I am a member of the peer team and a baby professor. I forget. Associate professor with, or assistant, no, assistant's the lower one. See, I'm still new to this, but with the U of A, and I also work, do my clinical work at the Boyle Macaulay Health Center with Tally and a bunch of other awesome colleagues there. So let's move into briefly why we're talking about this. I think if you've come here at 7:30 on your Thursday, you probably are passionate about managing this disease in your patient population. But just in case you thought this wasn't a big problem, shocker, you're wrong. So a very large amount of Canadians, almost 20% in 2018, over the age of 20 reported themselves as heavy drinkers. Like, that's shocking. In 2017, the rates of hospital admissions were impressive, to say the least, right up there with heart attacks, and actually 13 times higher than opioid-related admissions. And since it feels like sometimes in Alberta, we're really focused on money and ways we can save money, I've got one, and that would be to help treat our patients that are struggling with substance use disorders. And so you guys don't need to be educated too much that this is a major burden on our economy, and to the tune of $38 billion in 2014, with alcohol and tobacco taking up the vast majority of that. So yeah, we've got places to save money and people that are struggling that we can help with treatments and different options that we're going to talk about today. I've said many times in presentations, I think if you've seen me talk, I've told you that I'm a simple person and I like simple things, and that holds true here as well. The Canada's Low Risk Alcohol Drinking Guidelines is a really nice trifold pamphlet that you can pop into your office that basically outlines at what point maybe someone might be considering that their alcohol intake is starting to have an impact on their medical health. And also the single alcohol screening question is a great way to screen your patients just by asking, in the past year, how often have you consumed more than 3 for women or 4 for men, or drinks on any one occasion? And easy question with an easy answer. Being a positive screen is anything above never or 0 or not at all. Now, that doesn't mean your patient has alcohol use disorder, but that does mean that you're going to want to talk a little bit more about their alcohol intake and find out a bit more about what's going on there. And the nice thing about this single question screening tool is that it has a decent sensitivity when you compare it to reference standards like the CAGE or the audit. So in December 2019, the BC Center for Substance Use, or BCCSU, came out with a really, really thorough document on high-risk drinking and alcohol use disorder. It's 190 pages and there's 732 references. This document is like a Bible for alcohol use disorder and is incredibly helpful. And so if you want to really dive deep, then this is a place to go. I've pulled up a table that talks about diagnosis because it actually goes through the DSM criteria, not only what those criteria might be, but giving you questions that you could ask to look into that specific area. I wouldn't say I use this in my practice. Most of my patients, when they're coming to see me or when I'm screening them about their alcohol use, if they're using alcohol, it's probably problematic. But I more go to my mindset of the 4 C's, which are use outside of your control, having cravings, having compulsion to use, and using alcohol despite of consequences. And that would be when I would start to really think that we need to talk about where somebody is at their stage of change. So Tally's going to talk to us a little bit more about screening and what to do next.
Excellent. Thank you, Dr. Kirkwood. So if your patients screen negative, that's great. I think it's important to give them feedback on the health benefits of what they're doing. And you can give them that trifold pamphlet that Jess talked about, the low risk drinking guidelines. And then it's important to screen them annually because obviously drinking patterns can change with life situations and pandemics. So it'd be important to screen them annually and just see if anything is different. Now, what do you do if they screen positive? So you might want to get a fuller picture of their alcohol use. As Jess mentioned, the single question is a great screener. 2 longer questionnaires that I like are the audit, or the audit C, which is actually even shorter than the audit questionnaire, and the SAD-QC, which Lana will talk about a bit later in the presentation. So your patients can even fill these out while they're in the waiting room or while you see another patient. And they give you sort of a fuller picture of their alcohol use and make it a bit easier to sort of see where they fit, if they're at-risk drinking, if this is a alcohol use disorder. And if they do screen positive, we're going to talk about what the next step would be and what a brief intervention and referral to treatment looks like. So next slide, please. So what is a screening, brief intervention, and referral to treatment? So you might have seen this acronym. Sometimes there's an S at the beginning, sometimes not. We've talked briefly about the screening. It can be as short as 1 question, as Jess mentioned. The brief intervention portion is a discussion around the patient's drinking to sort of increase awareness of the potential harms of their current use and help motivate them toward lower risk drinking levels. So something below the lower risk Canada drinking guidelines. Now, this brief intervention can be done for at-risk drinkers or those that you've diagnosed with alcohol use disorder. Now, the referral to treatment portion is, as it sounds, a referral to further resources or specialist care. Now, strictly the definition says that this portion should be done for people with alcohol use disorder and not necessarily those that have at-risk drinking. But I think you could tailor it to someone with at-risk drinking and maybe tailor some of the resources to them. I mean, I don't think they necessarily need to go, for example, to a detox, but perhaps some resources and some counseling in the community could be appropriate for someone with at-risk drinking. So is there evidence for this? Why do we do this? Why should we do this? There certainly is evidence that this makes a difference in people's drinking. And I want to just underline that brief advice, even from a primary care provider, is effective. So in all kinds of areas. So reducing alcohol consumption, emergency room visits, hospital days, and healthcare costs in people with alcohol use problems. And during COVID times, recent research supports its effectiveness via phone or website as well. And I think it's important that, this doesn't have to necessarily be done by you. It can be done by allied health providers. If you have a behavioral health consultant in your office or a nurse that the patient is sort of familiar with, you could also sort of bring them in and get them to chat with the patient about their alcohol use. Now, obviously, if they've never met a nurse or behavioral health consultant, due to the stigma of alcohol use, you may not want to say, oh, you drink, great, you screen positive, let me bring someone in and we'll intervene here, obviously. But I think it's important to know that, in most of these studies, the brief advice was less than 5 minutes or 5 to 15 minutes. So certainly something that you could do in an office visit with someone. So how do you do a brief intervention? I think, I learned about this. I remember learning about this in residency in medical school, but no one ever sort of taught us how we would go about doing it. So I found a nice acronym, which is FRAMES, to sort of give you a framework for how to do a brief intervention. And the slide is a little bit busy. I've given you some sort of talking points on how you would go about sort of talking to someone and doing a brief intervention, but I'll just go through the acronym and talk a little bit about each portion of it. So F is for feedback. Now, the important part of this feedback is that it's individualized feedback for the patient. So if you've got them to do one of those questionnaires, you could sort of, compare their score to people matched for age and sex from the general population, because that's what they've done in the studies and that's what has been useful. Or for example, if someone came in and their liver enzymes are a little bit high, or they've been in the emergency room with some kind of sequelae of alcohol use. Just providing individualized feedback is the important part there. And I think it's also important to ask what they think about what you're telling them. Because if they don't want to talk about it and you're sort of shoving this down their throats, you're not going to get too far either. So I'd like to say something like, your score on this questionnaire indicates a high risk of problems from your current levels of drinking. What do you think about that? And that sort of is a nice opening for opening the conversation and talking about it a little bit further. The R in FRAMES is for responsibility. Now, when patients realize they're responsible for the change process, they tend to feel more empowered and invested in it. And obviously that results in better outcomes. You have to be careful here. It can sound a bit judgmental if you were to say something like, now you're responsible for quitting drinking. Of course, no one would say that, I think, in reality. But you could say, I'm here to support you no matter what you decide about your drinking, because it is their decision at the end of the day, obviously. I think it is sort of, as healthcare providers, still so important to give people advice. Because, not everyone's aware that their drinking levels are dangerous. And so I think it's important to just mention, you were drinking at or the best way to reduce your risk is to drink less than 3 drinks per day, for example. And it's better not to tell people what to do. Suggesting obviously leads to better results. M is for menu of options. Now, if clients are free to choose sort of what they want to do about their drinking, they're going to resist your suggestion, I think, a little bit less and dismiss your ideas a little bit less. And this is the part where I think maybe many family doctors aren't as strong, because knowing what the options are to offer people, I think is not something that we're taught in medical school or residency. The E in FRAMES is for empathy. I think we all get that. Obviously there's a lot of stigma around addiction and alcohol use, and being non-judgmental, empathetic, and respectful is really important. The S of FRAMES is for self-efficacy. Now, the way I think about this is sort of pointing out to patients that they've probably tried to cut down in the past, or most people have for certain parts of their lives been successful in cutting down. If it, for women, it's when they were pregnant, or for certain events or things like that. So I like to say, how have you cut down in the past? And once you identify their strengths, you can help them to build on these successes for the future. Often they forget what they used to do. And that's an easy way to sort of bring some attention to the fact that they can do this, and also expressing confidence that they can cut down if that's what they want to do. This whole process takes less than 5 minutes. So it's very possible to do in a busy office. And I think that's important. We're all very busy. So like I mentioned, the menu of options part of the brief intervention is, I think, where we don't have a lot of training and it's hard to access resources. So what I wanted to do for the next few slides, and what Lana and Jess are also going to talk a little bit about, is what we can offer people. So I'm going to talk about just day treatment and 12-step groups and where you can find resources for that. And Lana and Jess are going to talk about detox and medications. So the first website I have there is an AHS website. Best to copy and paste that one. Obviously, it's really long. That website has a drop down, so you can search by service type, and I would search addictions and substance use. And it's nice for even small communities. So I put Fort McLeod in there, and they will search up only AHS facilities, but it's good for finding day treatment programs. So perhaps you're at risk drinker who doesn't have full-blown alcohol use disorder, wants some resources, maybe wants to connect to a counselor. I found really hard to find that information anywhere else other than this website. So that might be a good thing to bring up and sort of direct them to AHS resources that way. Now, if they want to go to residential treatment, something good that this government has done in the past few months is in November, they actually eliminated fees to attend publicly funded treatment centers. So any residential treatment, which is treatment that you stay overnight at, is now covered by the province. Now, it's important to know that people on ASHRE Alberta Works would be covered anyway. So this hasn't made a difference for them necessarily. And people with treaty status are covered to attend any NADAP facility. And NADAP is, if you Google it, you may not find it. It stands for National Native Alcohol and Drug Abuse Program, which is quite an antiquated term. I think that's why they use the acronym mostly. It's NNADAP. So that's a good thing. So for your working poor, or people that aren't on Alberta Works, where the hurdle to go to treatment was too big, I think this will make a difference for them. And then where do you find these residential treatments is the next question. So this is the most inclusive website that I've found. Now, this isn't necessarily a government or Alberta Health Services website, but it has all the AHS treatment centers, as well as private centers and publicly funded centers and detoxes. So it's really great. And it also has links to all the treatment center websites. Which is really important. You could pull this up in your office when you're with someone. Oftentimes people have found a treatment center that they want to go to. They just don't know how to go about getting there. So if you pull up their website, you can often print out an application form. Most places need a medical done by a primary care provider. So you can either do that day or get them back at another visit to do the medical portion. And then you can even fax it in for them. We do that here a lot. Oftentimes we find it gets lost between leaving the office and trying for them to fax it in. Of course, it's not easy for people to find a fax machine these days. So this website has all the NADAP treatment centers for any of your patients that have treaty status. They would be fully covered. So this website's nice because it lists all of the centers across Canada and sort of their criteria. So there's some for youth, some for just women. Oftentimes, transport is covered to these places too, because they're often on reserve or quite remote. So that's something to keep in mind. And then don't forget about 211. 211 is a relatively easy resource for patients to call. The website is not great, if I'm honest, but the phone line is useful because then there's a living person there to help you find some resources. So don't forget about them. And then the last thing I'd just like to mention is self-help or 12-step facilitation groups. Now, there is evidence that these work, especially for people that have familiarity and have attended AA in the past. They can help people certainly cut down on drinking. The trick is you need to refer people to open AA meetings. If they try and show up at a closed AA meeting, they won't be able to get in unless they're an AA member. So I sometimes pull up the website in the office and actually find a meeting while we're together, and then sort of make a goal for the person to attend that meeting in the next whatever time frame you kind of both agree on. That's the Edmonton site, but if you just Google Alcoholics Anonymous Alberta, you can find other sites for the rest of the province. I'll hand it over to Lana to talk about detox.
Awesome, thanks, Tally. I'm just going to jump in here talking about detox. So a couple of things we wanted to do this morning. So one is to sort of demystify that this can be done in community successfully. I sort of got thrown into it. Patient showed up, wanted to do it, had done it before. I had never done it before. So with some guidance, I did some prescriptions and then followed up with her, and we did fine. And we've done it a few times since, and a few other patients as well. So just to let you know, people actually do it in community. It can be done. And to be honest, the patients are experts at detox themselves. because a lot of them are actually detoxing themselves at home, sometimes with benzos, sometimes with alcohol. So, in terms of thinking to yourself, I'm not so comfortable. Is it really safe? Should they be in hospital? Trying to remember that they're doing this on their own anyway, a lot of times. And the way I think of it is I'm just making it easier for them. So it just kind of removes that barrier sometimes that they just find it too hard or they feel too unwell. And sometimes it's even just for something temporary, like, I have a patient who really likes to bead, and then she gets a contract and she's too shaky if she's drinking. So she sobers up for a month and does her stuff and then, kind of goes back to it. So it can be done, just to encourage you guys. The other thing too is that we have access now to this secret document. AHS actually has a home detox protocol. It's not easy to find. Kathy has the magic password to get in there. So she shared it with us, but we are going to share it with everybody who's attending today, and feel free to share widely. I'm just going to go over some of the highlights today so that you guys have a better idea of what's in there. So inclusion criteria, who you might want to be thinking about using this with. Basically, it's just based on safety. So you're looking at patients who are stably housed, have an environment that's conducive to treatment. So maybe, not a ton of other people drinking in the home, for example. Medically stable patient that they they consent to undergo treatment in community. There is an AHS consent to treatment procedure, something that I do not have, and maybe Kathy could scrounge that up for us, but basically just consent. And that there is someone, that's a big one, is that there's somebody around. I mean, it doesn't have to be a family member, but somebody who can stay with the patient and just kind of be there in case they get into trouble. And then another big one, which, oftentimes with this population, they just do not have stable phone access, whether they have a phone and they have no minutes, or they don't have a phone, or they use someone else's phone. So of course, just making sure that you can call them and follow up and see how they're doing. In terms of who should not be doing this in community, so anybody with complicated withdrawal, seizures, DTs, those guys are higher risk. Probably, I wouldn't feel that comfortable doing those guys, and there's other places where they can be supervised. I'm going to talk about the screeners you can use. So there's the SADQC that Tally talked about briefly, and the PAUSE is the prediction of alcohol withdrawal severity scale. So we'll go through that and then what scores would be appropriate and which wouldn't. I wouldn't feel comfortable with a patient having acute psychosis or unmanaged psychiatric conditions. I think it's pretty obvious. Medically unstable for any reason and inadequate family support. So just basically the flip side of what we talked about before. Inpatient detox, so they can go to hospital. I know in some small communities, smaller communities where the hospital is the closest thing, and I mean Kathy could speak to that. I'm sure they do that down in Pincher, where sometimes the detoxing is done right in hospital, and in Calgary as well. There's programs where they do that, but there are a lot of other centers in the province where not necessarily in hospital, but they can get supervised detox out in the community. So I just put together a list of those places. These are all the ones that are in Alberta. I don't know too much about the ones that are outside of our region, but I know, for example, at Renfrew, that's in Calgary, and I think it's similar in Edmonton, the patient basically shows up at a certain time in the morning. So it's kind of like walk-in. They sit around in the waiting room. I don't know what's like in COVID, but they basically bring them in for one-on-one interviews about their situation, when their last drink was, that kind of thing. They have to have been drinking. So they don't generally take patients who are already sober, which kind of makes sense. And then they kind of come up with their list, they fill their beds, and they send everybody else away. So it's kind of it's the process that they use. I mean, it works for them. And then of course they medically supervise. It doesn't have to be alcohol. They take people with other substance use disorders as well. And just a tip, if you live outside of an urban center, for sure at Renfrew, if we're calling from a rural area, we can often book a bed ahead of time. So we're the only ones that can do that. And it is just because, it doesn't make sense for a patient with limited means to transport themselves to Calgary only to be turned away. So if you're in a more rural area outside of a center, you can call into these urban centers and try and book a bed for your patient. They still need to talk to the patient, though. That's one thing to know, is that it is a self-referral. So even if you're booking a bed for the patient does have to call them and confirm that they want to go there. So you can help set it up, but they have to talk to the patient. In terms of professional standards, so these are just kind of documentation guidelines, physicians, NPs, we all have kind of our own regulations, and they're basically just saying make sure you document that in the chart, which I'm sure we would all do, so that's pretty straightforward. The withdrawal assessment scales, so they're both validated tools. They're a little different. So the pause is much more focused on previous withdrawal symptoms and complicated withdrawal. And the SADQ-C is actually more like a detailed CAGE questionnaire. So it asks a lot of the very similar questions, but it really quantifies it. So, in terms of like, if you need to have a drink in the morning, how many drinks, that kind of thing. So it's a lot more detailed that way. So I'll just flip to the next one. And these are just pictures of them, not meant to kind of provide you with details, but you can just Google them with everything else. I don't think you have to pay for them, so you don't have to feel bad about that. But the SADQ-C, so it's actually several pages. So that's a 4-point Likert scale. It's 0, 1, 2, 3 scored based on their almost never, sometimes, often, nearly always. Over 31, a score would be classified as severe alcohol dependence. 16 to 30 is moderate. Less than 16 is a mild physical dependence. And as we go to the next page, you'll see that this AHS protocol is based on those scores in terms of what you're going to give them. I'm just going to back up to the pause for a second, Jess. So the pause, there's a max score of 10 on there, and that one's pretty straightforward, and it has really to do with delirium tremens, seizures, blackouts, like really withdrawal symptoms. In C, if you're in the hospital, there is a point for blood alcohol level if you're actually taking blood work, which lots of times in community we aren't. But you can also estimate that based on how many drinks they've had in the past 12 hours, and it gives you that there to use if you need. Okay, so the next part here is the actual detox protocol that they set out in this guideline. And I would say, like Jess and I have done a few of these in the community, and I was relieved to see that this is basically what I do, so that's good. There's basically 2 levels. So they're saying, you should be looking at the score. So SADQ-C less than 16 or pause less than 2, which basically means they haven't had complicated withdrawal or not very complex, no additional medical concerns. So it's spread over 5 days. There are other protocols that do not use benzos. We had a discussion about that when we met up in Edmonton way back. So there are alternatives, but this is just what they have outlined in the AHS protocol. And so it's a tapering over 5 days. So the difference between that one and the patients who would have a higher score is not much. It's just that they add on an extra day of 10 milligrams 4 times a day before they drop it down. But otherwise, they're exactly the same. So one is spread over 6 days, the other one over 5. And if you have a higher score, they initially give you more. So they also include things that you would not necessarily think about if you have not gone through alcohol withdrawal yourself or more mild alcohol withdrawal. So to be thinking about, what are the other symptoms that they may be having that would be distressing, and to provide them with that. I have a prescription favorite that is my home alcohol withdrawal thing, and I send that whole thing to the pharmacy, and then patients don't have to take it all if they want, but I tell them what's on there and they can choose to fill it if they like. So hydroxyzine I don't typically use, but you definitely could. And the common antiemetics, whatever you're comfortable with, analgesics. I don't typically have patients complain of fever, but you definitely could. Magnesium, I don't standardly prescribe that, but perhaps it'd be a good thing to mention, and they could kind of request it, or you could check in with them and see if they're needing that. The next slide is just talking about acid reflux, which they can sometimes get. I thought the constipation was interesting. My patients tend to get diarrhea, but I guess it's just, make yourself aware there can be poo problems, and, whether it be constipation, or I provide actually Imodium to patients who are withdrawing, but, just that discussion. Well, you don't really need to tell the patients what the withdrawal symptoms are. They already know. So it's not a bad idea to kind of ask them, what are your symptoms typically? Do you get constipated? Do you get diarrhea? Do you get muscle cramps? Do you think that would be helpful? So having a discussion with them that you're trying to support them, like Tally said, no judgment, decrease the stigma, just very straightforward. What are the symptoms you get? I really want to support you through this, make it easier, come to me if you need the support anytime. I haven't used the one for gastrointestinal cramping as well, so good to add to the list. The other thing that they have on there that's useful, and I didn't put those in detail here just because our talk is about alcohol use disorder, but there is one for stimulant withdrawal. There is one for nicotine replacement, which is pretty straightforward. And then there is one for cannabis use disorder as well. So if you're getting keen about doing home detox, or you just want to check it out and see what's there, there's actually quite a lot available in that document, and maybe Carrie can let us know how that's going to get sent out afterwards. I will pass it along to Jessica.
Awesome. Thanks, Lana. That's so helpful. Yeah, I would say I've had the opportunity to work at the Edmonton Isolation Facility, which I spoke with this group about before, where we're providing shelter for people with COVID symptoms and COVID, and seeing the amount of alcohol withdrawal people have gone through, and how uncomfortable they are. And then also how well they tolerate their withdrawal when they're given a benzo schedule is really great. And also it's pretty easy to tell who's not doing well and that needs to then go to hospital. So yeah, I really appreciate that document. It was a good one. So I'm going to quickly talk about pharmacologic options for alcohol use disorder. And this doesn't need to happen only after somebody's gone to detox or gone through a withdrawal. If they're still drinking, they're at any stage in the game, you can talk about these medications with them. But I would say that I would talk about goal setting before I would jump right into treatment options, because I think as doctors, we can often assume things, and you know what they say about assuming things, so not great. And certainly I use the example, if a patient came in and said like, doc, I had 2 drinks for Thanksgiving, and my response was like, oh darn, what happened, when that was a massive success. Like last Thanksgiving they had 20 drinks and they knocked the turkey over, and and they've got into a fight with everybody. That like I would have really missed the boat. And so traditionally abstinence is talked about as a primary goal, but that's definitely not the case for everybody. And so looking at whether it is maybe only drinking specific beverages, or eliminating non-beverage alcohol or something like that, maybe looking at less binges, or sobriety for specific events is a big one. I find that maybe people that don't have their children in their custody and have had to miss out on a visit with their kids due to their substance use, that's really, really devastating. And so to say that there's ways to help them deal with cravings and with their substance use disorder, so that their next visit doesn't have to be like that. They're just different things to talk about. Straight into meds then. First line treatment options are naltrexone and acamprosate, and I've just pulled this table right out of that BC guideline. I'm not going to go through all the comparators, but some things to note would be naltrexone being an opioid antagonist would not be ideal for patients who are either co-prescribed opioids or who are using opioids. That one's not going to work so well. And alternatively, acamprosate wouldn't want to be used in a patient who is breastfeeding, and you might want to think about pregnancy is a caution on there for sure. So there might be other better options for that person. Cost-wise, pretty similar, also fully covered for Alberta Blue Cross and NAHB, and lots of different plans. On here it's for BC, so just you can kind of ignore that if that doesn't apply to you. And talks a little bit about maybe doing some liver function testing. Someone with pretty severe liver issues, cirrhosis or end-stage liver failure, you wouldn't want to use naltrexone for. Alternatively, renal impairment is a contraindication to acamprosate, severe renal impairment, that is. And then lastly, dosing. Naltrexone, you start out with a 12.5 BID for 3 days, and then you pretty quickly move into a once daily dose of 50 milligrams. So that's quite nice, having a once daily medication, because alternatively, acamprosate has the most satanic dose of all the medications I prescribe, which is 666 milligrams 3 times a day. No idea if 650 or like 670 or something were taken, but we really went with that. And so that's the dose. And so sometimes that TID dosing can be limiting. And so what's the actual evidence for these medications? Well, sifting through the evidence, as I've done twice now, once as on the bit of a back burner when Fehr did our first tools for practice on acamprosate and naltrexone, and then I had a more involved role in our gabapentin tool. I found that that the evidence in alcohol use disorder is really, really interesting, and that has a lot to do with different outcomes. And so you'll have a systematic review that looks at it has lots of evidence. I mean, we're looking at like 16 RCTs and almost 4,000 patients for that first one for acamprosate, but the outcomes aren't all the same. And so, which is makes sense. I mean, just like I said on my goal slide, abstinence isn't the only thing. And so if I only knew the evidence for abstinence for these meds, I think that that would not be ideal. And so in all these slides, what I'm going to be looking at are two outcomes. One is return to any drinking, and one is return to heavy drinking. And so when I'm talking about return to any drinking at all, that would be that abstinence. And then returning to heavy drinking would be just kind of drinking less. So to look at acamprosate, in the RCTs that we looked at, the most common dose was that 666 3 times a day. And we found that 76% of people on acamprosate returned to any drinking, whereas 83% did on placebo. So that gave us a number needed to treat about 12. For abstinence, naltrexone didn't have as good of evidence. Again, dosing was at 50 milligrams per day. And it was about 63%. Sorry, what is happening to my voice? 63% of people on naltrexone versus about 68% on placebo, or a number needed to treat of 20. Returning to heavy drinking, that was where naltrexone had a bit better evidence, with 46% of people on naltrexone versus 54 on placebo, with a number needed to treat of 13. And there was no statistically significant difference with acamprosate. Not to say that if your patient's goal is to drink less, that you wouldn't try acamprosate with them, because I still think that this is an option, and giving any option is better than saying just don't do that, or giving them nothing if they're interested in medications. So, but just that the evidence wasn't there. Second line options are gabapentin and topiramate. I think that, yeah, gabapentin, we've all prescribed it for various reasons. It seems like it's just really becoming a bit more widely used. And so for the patients that you wouldn't prescribe gabapentin for other reasons, that would also apply for this population as well. And mostly the dosing was looking at about 100 to 300 milligrams TID, moving up to around a max of 1800 milligrams daily. Most of the studies were in this 1600 to 1800 milligram range, so on your higher end of dosing. And then topiramate, I was saying when we were preparing for this talk that it isn't something I use commonly because it does have a lengthy taper for initiating the medication. And then Lana jumped in and said, well, actually, I have patients who do really well on a lower dose. And so I'm going to shut up for 1 second and let her speak about her experiences with topiramate, because I was going to say, it's probably like my fourth choice. But it turns out that it's actually, she's used it more commonly and had some really good success with it.
Yeah, I'll just really quickly jump in. I did a substance use disorder, alcohol use disorder CME conference a while back, and there, was a bunch of different experts, and there was a doc from the States, and he said, topiramate is his go-to, and I was like, oh, okay, maybe I'll try it. And I tried it. I had a patient who kind of a rodeo background, and she, had grown up in a family with lots of drinking, was drinking a bottle of wine after work, that kind of thing, and just was realizing like that needed to stop. And another quite heavy drinker, and both of them at 25 milligrams, which is the initial dose, found that quite helpful. And the one patient has abstained completely for 3 years. I'm not saying that'll happen for everybody, but for her, it was like a miracle, she said. So, it's definitely worth a try. I have said, like, I have not gotten to the higher doses with patients, and I found that they respond really well, a few of them, to the lower dose. So I would definitely encourage you to try it.
Yeah, that's awesome. Thank you so much. One population you're going to avoid topiramate in, though, are those that are pregnant or planning pregnancy. That's a contraindication for that. So then, yeah, moving to the evidence, again, Fehr looked at gabapentin pretty closely in our Tools for Practice that came out in November of 2020. And so when we look at the most recent meta-analysis in 2019, their overall statement was kind of, it appears effective for reducing heavy drinking days, but no reported benefit for abstinence. But when you actually look at the two larger RCTs within that meta-analysis, the evidence actually looked a little bit better. So for no heavy drinking days, or abstinence, about 44.7% of people on gabapentin achieved that versus 22.5% on placebo, with a number needed to treat of about 5 or 6. And in terms of total abstinence, about 17% of people on gabapentin were able to, oh, sorry, I got that backwards. I think I did that the last time I gave this presentation. No heavy drinking days, meaning cutting back total abstinence, 17% versus about 4% on placebo, with the number needed to treat of 8. And so then I see those numbers needed to treat, and I go, well, why would gabapentin be a second line med? It seems like maybe it works quite well too. And I don't know, but I thought of some ideas, which could be that there's a lot of adverse events with gabapentin, with the number needed to harm about 4 for dizziness. So lots of people don't tolerate this medication. And there are some concerns about misuse of gabapentin. I know we're seeing certainly an increase in the prescription of gabapentin. And so we always have to make sure that we're not creating a problem when we're trying to solve one. And then topiramate has had, again, there's a lot of evidence lots of studies looking at this. My total numbers aren't there, but they're pretty similar in terms of number needed to treat. Maybe slightly better than naltrexone for heavy drinking and cravings, and about the same for abstinence. And so I had speculated that this was more put into the second line category, meaning that it required titration, and seeing that there are also quite a few adverse events with topiramate. But we could even have people here today that helped work on the BC guideline or that have looked into this closer than me. And if you have suggestions, then please feel free to speak up and pop them in the chat. We got a few more options that have been used, and so one would be baclofen. Unfortunately, it looks like the evidence isn't quite there for baclofen, but if you've tried everything and you have a patient sitting in front of you that's like, I just really want to find what works for me, I don't think I'd hesitate to give this a go. It looked like in the Cochrane review in 2018, as well as another meta-analysis with 12 RCTs, that there was no difference in placebo. But we can't forget that placebo has an effect, right? And also when you're looking at this evidence, I think we always like to be like, well, why would that look like that? Why would that turn out like that? I think you do have a highly motivated patient population if they're looking at taking meds at all, but also if they're looking at entering into trials. And so that's something to consider as well. I think that, again, if you have a patient that wants to try something, why not give it a go? Disulfiram is one, though, that I definitely in practice previously never would recommend, just because I really struggled with the idea that somebody would be punished when they drank, and so disulfiram is also antabuse, where you feel quite ill if you consume alcohol when you're on this medication. And I just really struggle with that one, because I know all of my patients just have they really beat themselves up inside their minds. They have had lots of really negative things happen to them due to their substance use. So then to put them on a medication that physically punishes them, that just never sat right with me. And so I was quite happy to see that there was not great evidence for disulfiram. And so I didn't feel like I was really letting people down by not suggesting it when it felt like at one time that was our only option. And then on ondansetron, actually in teeny weeny doses, I've heard other speakers talk about this being something that they've used in their practice, but right now, not really great evidence for clear recommendation for that. So how on earth do you decide? Do you feel like this woman with all the question marks? Well, I mean, I think it's just coming down to having a conversation with your patients. Due to some of the contraindications, you can probably check some off right away, looking at things like availability, and maybe giving your pharmacy a call to make sure that the medication is available to them. Maybe looking at that dosing regimen and just talking about patient preference, I think are really great. Apparently I felt so strongly about dosing regimen, I put it on twice. So that's that wasn't done intentionally. All right, we've come to the end of our talk, and it looks like we've left some time for questions, but just really quickly to summarize some of the things that we covered today. We talked about screening. You don't know if you don't ask, and I think that as primary care providers, we are expected to do so much. So this is another one that gets added to the plate. But again, the idea of maybe involving your allied health staff, maybe using your EMR for reminders, using questionnaires that people can fill out. There's different ways to do it so it doesn't fall all on you and chew up all the time that you have with your patient. Then moving forward to a brief intervention, which has evidence for help and referral to treatment. Really enjoyed Tally's kind of outline there in terms of frames of specific examples on how you can say things. I've been so lucky in this time of COVID to get to sit directly next to Tally and listen to the way she interacts with her patients and how she speaks. And she's not just paying lip service to what she says. She's really so empathic and caring, and it's probably like one of the best things of my job is that I get to continue to learn from people like Tally. And I can just in my head say, WWTD, what would Tally do whenever I'm, struggling that way? And then providing that menu of options. I do agree that I think in our training, we're not really given all these tools in this toolbox. And so it can feel really, it can be a topic that you might want to avoid if you feel like if a patient said, what could I do, doc? And you open an empty toolbox for them. I think now, as we get to know more resources, even having these websites that we can kind of cue to, if someone says they're interested, to be able to then take that next step and really guide them in the right direction for them. Detox options, I loved hearing from Lana, and as like I say, in preparing this presentation, hearing more about the work she does and the incredibly important work that she does, and developing a bit of a comfort around being able to help people safely and comfortably detox at home. That AHS document is really helpful, and it actually was super for me, because I kind of felt like I was maybe doing something bad or something wrong when I was sending people home with benzos. You don't need to send them with a bucket of benzos either. I mean, a lot of places have pharmacies that could even deliver daily to be able to check in on them or something like that. That's not true for everyone. And if you don't have that service, you can still safely allow people to detox at home. And again, just being able to see how much people struggle when they've come in to seek shelter from us at the isolation facility. I've really said wow, this is something that I think I could do better. And then lastly, looking at goal setting with your patients may not be what you expect, so it doesn't, or it's always good to ask. And we talked about some pharmacotherapy options and the evidence for those. So I don't know if I should stop screen sharing or maybe leave it up so that I can quickly go to a slide if I need to, but I'll let Kathy or Carrie jump back on and we can see if we have any questions for us.
Yeah, well, thank you guys. That was great. And there's a few questions and comments in the chat. And I noticed Lana's been busily answering some of those, but I'm just going to go through it. There was first of all, that AHS document for home detox, we will send it out to everyone along with the slide deck. And so you'll have both that document from Alberta Health Services as well as the slides that have those websites, et cetera, on it. We'll also take all those and post it in the resource library and on the discussion board for the CMN so that you can come back to it just to answer that question. And we, Lana, we had a couple of comments from Mary and Tanis just saying that when you were discussing Renfrew and having to go and then have an interview, and then when the beds were full they had to go away, but if you were out of town you could phone, and similar process in Edmonton and in treatment center in Lloydminster. The patient had to phone every day to see if they could get in, but just wanted to let people across the spectrum in Alberta and elsewhere, how that process works. Muriel Solomon asked, how does Librium compare to the diazepam when you're doing home detox or detox generally?
Yeah, I saw that. I'm not sure. And I remember back, Jess was just talking about when we met. I know we were chatting about that and somebody in the room had more experience with that, but I personally have only used benzodiazepine, so I don't know if there's somebody else who's listening who has more experience with that, but unfortunately I can't answer that question because I'm not sure. Maybe Tally knows more, I don't know.
I can jump in. I work in the hospital at the Royal Alex where we do lots of complex detox, and we're using Valium almost exclusively. But I do know that, for example, at other hospitals like the University in Edmonton, they're using more Librium. I don't know that there's evidence for one more than the other. We're just trying at the Alex to sort of streamline and have more consistency in what we're doing. So we're mostly using Valium unless someone has sort of end-stage liver disease and the metabolites of Valium can build up. So then we're using Ativan in those patients.
Right.
Yep, I would just echo that as well, that at the isolation facility, we're sticking with diazepam and Ativan and have not used Librium at all.
Hi, this is Muriel. It's Muriel, not Miriam. Anyway.
Oh, sorry.
So yeah, it's okay. It's Muriel Solomon. Yeah, in the old days, we used to use Librium, and it's a benzo as well, but probably more longer acting. But the thing is, I was concerned about if you use diazepam and you're trying to detox them every so often, do they not then get a dependency on benzos? How do you then go from one problem to another problem?
Yeah, not in my experience. I mean, I think that our tapering and the protocol that's outlined in the guideline is quite short. So, I mean, we're seeing patients really settle around that 3 to 5 day mark, and at the isolation facility, it's guided by a CWAS score. But that reassures me that in community that would be similar, because there's nothing more that we're offering outside of supportive management. So yeah, you're able to just stop the prescription. I mean, if you choose to continue a prescription for weeks or months, then absolutely, I think you're potentially creating a problem. But if you outline from the get-go that this is a short-term prescription purely used to get you through this period, then it's not a problem. I don't know if Lana or Tally, you want to?
Yeah, Mary, I would just add into that. So I also struggle with the whole benzo thing. I have kind of a benzo block in terms of using it for things because of that worry. But I would say one of the things I do that I find helpful is, I link the medication to the specific symptom that we're treating. So the patient is very clear. So, they're having withdrawal symptoms. It will help with the withdrawal symptoms. When the withdrawal symptoms are gone, they don't need it anymore. So we're just very, very clear on what it's treating. And, I don't talk about how it's used for treating anxiety. If they have comorbid anxiety or ADHD or whatever it might be, then we look at assessing those and treating those. But I do find, a lot of my patients with alcohol use disorder, they don't necessarily want to address maybe the underlying mental health conditions at that time. They're just kind of in a survival mode. But they do see this as a means to an end, and they're quite happy with that. So I have the same experience, that they're not asking for more or sort of needing it, as long as they know kind of what we're using it for. And I think they are also grateful to have it, and that they, are grateful to have that assistance, and happy that it helped them in the way that they did. And they sort of focus on that, and they seem to be quite happy to just stop it when they're done.
Oh, thank you. The other thing, quick question is, what about using Ativan instead of Valium? Because I remember one of those old, manuals that you carried around as a resident, the recommendation was using Ativan.
Yeah, we're using Ativan. Oh, good. Go, Tally.
Yeah, sorry. We do that in hospital just for people that have a sort of end-stage liver disease, because it's shorter acting. So the withdrawal is a little smoother if you use a longer acting benzo like Valium or Librium. So the only reason we're using Ativan is because of the toxic metabolites that build up with Valium use.
Yeah, thanks, guys.
Thank you.
Yeah, just noticing in the chat, there's lots of discussion, interesting, different facilities using different things. Drake has been working Lethbridge Recovery Center. They use both, and Librium is first line, which is which is an interesting comment that these are, AHS supported facilities, but with different protocols. And I know our hospital protocol, I don't know if Flory can, we choose between Ativan and diazepam on the sort of check boxes that we do for hospital detox. And we see the Addiction Recovery Center in Edmonton uses diazepam, Valium, or Ativan, lorazepam, and they're trying to match those protocols. So there's lots of discussion on that. Christine Kennedy had a question regarding the Sinclair method. Is anyone familiar with that and the evidence for it? I think it uses naltrexone, but I'm not sure.
I'm not familiar with evidence. I can speak to that briefly. So my understanding of the Sinclair method is using naltrexone sort of PRN. So if you had, for example, an event coming up on the weekend, which you wanted to drink less, you would take some naltrexone a few days before. I don't know the evidence, and I don't have patients that do that. I find if you're taking a pill every day, it's going to be a heck of a lot easier to remember to take it than in anticipation of a potential event, because I find that anyways, with my patients, most of the times they're triggered to drink. It's not something that is planned too far in advance. So maybe for another sort of patient, it might work if they have a wedding or something like that. I don't know the evidence though.
Great. Thank you. And there was a question about drug plan coverage for acamprosate. Is it widely covered like naltrexone now? Any comments on that?
I just did a little bit of digging while we were talking. So NHB, so if it's a First Nations patient, it is covered. I went on to IDBL just to look at the Blue Cross coverage, and it looks like it's special auth. So you have to fill out a form. The form is on the website, but just, yeah, you have to submit the form ahead of time. And it looks like the form, the special authorization lasts for 6 months. So it looks like you have to renew it every 6 months. So
Great.
that'd be probably anybody on Alberta Works or Blue Cross.
Okay, thank you.
Yeah,
then,
and just, sorry, Kathy, really quickly, just to plug, if you're looking for anything coverage-wise, Fehr has a pricing document that's
Right.
updated regularly. And so right within that document, it says Alberta Blue Cross, IA, or NIHB. And so you can see what is covered. And then the estimated like 90-day cost of any drug. So not just for substance use disorders, but really helpful thing to look that up. Sorry, continue, Kathy.
Yeah, no, that's it. Good comment. And we'll post that document too, just so people see it in the resource library, because it is super handy. We have another question is, how would you deal with clients who repeatedly return for alcohol withdrawal and home detox?
I have that experience. I would say I don't deal with them any differently than anyone else. You know, I think I just look at them as part of the spectrum of treatment for an assessment for alcohol use disorder. And, you know, I approach them similarly. They're just, I would say, I don't know, I'm not sure. And I don't know what the other ladies would think of this. Like, I don't know if that's really a measurement of severity of disease. You know, I appreciate that they come to me for help when they need it. And I know that I have a lot of other patients that don't. So I don't know, in some ways, maybe that indicates a readiness for change. I'm not sure. I don't know that there's a ruler that says what that means exactly, but I personally don't have a problem with it. You know, if I know that the patient is actively drinking and the stage of change is that that's kind of where they're at, and this is what they're doing to reduce, I'm quite happy with that. I mean, if they come back every week, that's a different matter, but I typically have patients who come maybe every 3 months, something like that. And I'm quite happy to support them every time.
Yeah, I would just have to agree with that. I mean, I think that let's say if we compared this to the diabetic whose A1C is not in a range that we think is best, or when someone says I'm going to quit smoking and then they come back the next visit and they're still smoking, we're not like shocked because this is really challenging. And so I just would echo that. I would really try to stress that I'm happy they came to see me, and because I know they have other options, and the fact that they're coming to see me shows that they're motivated and that we'll just continue to try different things. And I think having a wide variety of options to help, and if they say no, I just don't want to do this because I think if I can detox, then maybe I won't drink for 2 weeks, and okay, well then that's, you know, that's something, and they're trying at least. So definitely not discouraging them from coming to see me would be really important.
Yeah, I think, yeah, that's a great answer. And I think from my experience, you never know when they're going to be successful. And, you know, it can be someone that you're seeing repeatedly in a small rural emergency, and then suddenly you don't see them for so long and you find out they're, you know, back at university and got their kids back. So it's worth just continuing. And that example of it being like any other chronic illness, you know, we don't give up on diabetics or COPD or smoking cessation. So yeah, so just keep at it. And I agree fully that at least they're coming and wanting help. So you never know when it's going to really stick. There was just a comment on the AHS protocols, and they do use Ativan and diazepam, but interestingly, and this is great, is that it seems our residents in Pincher Creek use diazepam, which is, you know, the first line, and they're bringing their knowledge from elsewhere. And so just a plug to continue taking residents and be teachers. So it helps your own learning. And I think